Welcome, everybody. I'd like to thank you for joining the Pulmonary Pearls Educational Series live stream. So Pulmonary Pearls is a quarterly live stream program that was developed to discuss the current best practices to address respiratory diagnoses and ongoing treatment considerations. Participants will receive a link following the program for an evaluation. You can also use the QR code that will be displayed following the live stream today. Moving forward, I want to introduce our speaker. I'm happy to introduce Dr. David Hasselbacher. David and I have worked together on a number of initiatives, including readmissions, COPD task force, and system ethics, and I have found him to be a willing and valuable contributor on a number of projects that we've done together. So I know that today, much like his presentations he's done for our primary care review, will be informative and thorough. He is a pulmonary and critical care physician with Norton Pulmonary Specialist and working primarily out of Norton Brownsboro Hospital. He started with a career in research early by publishing in astronomy while he was an undergraduate at Vassar College. After sort of turning the corner in his life, he had conquered the universe in his astronomy field. He decided that turning to medicine would be a good idea and completed a master's in pharmacology while doing research on heparin dosing, and then later attended the medical school at the University of Louisville. He completed his medical residency and pulmonary fellowship at the University of Kentucky. He was then in a Norton-friendly private practice for 12 years before that practice and others joined Norton Healthcare to become Norton Pulmonary Specialist. He's been active since joining Norton in the efforts to enhance pulmonary care throughout the system. The only relevant relationship that needs to be disclosed is Dr. Hasselbacher does have a relationship with Boehringer Ingelheim as a speaker, and this relevant financial relationship has been successfully mitigated. Other planners of this activity have no financial relationships and with ineligible companies to disclose. So without further ado, I'll give you Dr. Hasselbacher.
All right. Well, thank you everyone for attending. Definitely looking forward to sort of having this conversation today about spirometry and COPD and the initial management. Really excited since coming under the Norton Healthcare fold a couple years ago to enhance the care for pulmonary patients in the city. So what we're going to talk today is really the summation of a lot of efforts from a lot of people, including, Dr. Jennings, Dr. Bright, and a number of other providers and clinicians here in our organization to create a pathway and try and elevate standards of care for COPD management. And this is really sort of the summation of that. So we're going to talk about a pathway that we've developed to sort of assist everyone walking through with these patients and give everyone a baseline. With that, we're super excited about getting spirometry into the hands of every single primary care office, because obviously that's a valuable tool in the use of COPD diagnosis and management. And so with that, we're going to be doing a sort of comprehensive intro to spirometry just to update everybody. And then finally, we'll touch on Alpha1 Antitrypsin testing just to sort of close things out. So here it is. Obviously, this was a lot of work, and we're going to walk through it today. It looks busy, but it's actually pretty simple when you get down to it. And frankly, what it really boils down to is we've got two of the big national worldwide standards for the management of obstructive lung disease here. In the bottom left-hand corner, we've got the GOLD criteria as it pertains to the national recommendations with regards to COPD management. And then over here to the right side, this is the GINA guidelines for asthma. And obviously, we've got a big linchpin that we're going to focus some time on here today, differentiating between the two managements of these populations, because there are some differences that we're going to want to address. So if you think about it, we've got both the gold standard and the GINA guidelines, here on one sheet of paper, and it's for quick reference. And so it's really not as complicated as it may initially seem. So what are we talking about? And the big thing here is COPD, and this is very common. It's preventable and treatable, related to that persistent assault of oxidative stress, usually from tobacco being the most common, that cause these abnormality of airways, structural and functional changes, sputum production, respiratory symptoms. And if we can identify and intervene early, we can really impact a patient's outcomes and symptoms. Unfortunately, we're way up here. We're very prevalent in the 8 to 10%. These statistics, as published nationally by the CDC, always a lag a few years behind. But we're very prevalent, unfortunately. And unfortunately, we're leading the pack with deaths as well, where we've almost 50 to 60 deaths per 100,000 annually. So this is a major deal. It's definitely highly prevalent in our practice. On a personal note, if you look out here in Colorado, if you talk in the pulmonary world, Denver National Jewish is sort of the epicenter for pulmonary hub. And frankly, we see so much and have so much COPD here, and Norton Healthcare is such a presence here in our community. My long-term goal is, we need to be the National Jewish. I mean, there's no reason as an organization that we can't provide the level of care that they're doing out there. This is a progressive disease. Obviously everybody dies of something at some point, and we can't stop that, but we can, change how we go about that process. And clearly this is the classic Fletcher diagram with a natural decline in lung function as we age. Everyone's born with all the lung function you're ever going to get, and it slowly declines. Thankfully, because we're born with more than we need, most of the time it's not a problem, and we get through life without issues with our breathing or our lungs. Unfortunately, when we throw cigarette smoking and susceptibility to damage on that, our lung function declines and can decline precipitously, such that we run into problems here later at life. The key here is that if we quit smoking, and this is where early spirometric diagnosis is so important, if we can quit smoking early on and stop this rapid progression, we can really have a tremendous outcome and reduce that chance of having that severe disability and death. And this is where in primary care, early spirometry, early diagnosis is key. I will be stoked if, 10 years from now, as we've introduced spirometry, earlier diagnosis, if I'm not seeing end-stage COPD patients as new patients, I will be super happy. And that's where this early intervention in primary care is going to be really key. So when we're talking about COPD, anyone who's, short of breath, chronic cough, sputum, who's had environmental inhalation exposures, those are people we need to think about. And we really have to have spirometry to make the diagnosis, because you have to have obstruction. And we have to prove that in order to make a diagnosis and confirm the illness. There's actually a recommendation from the National Lung Health Education Program where they push out this educational initiative to test your lungs, know your numbers. And the idea is that everyone who's a smoker, who's been greater at 45 years or older, should be tested. And they should know what their lung function is, because COPD develops slowly, as we saw in the Fletcher graph. And people can be asymptomatic. It is not uncommon, someone will say, oh, I don't have any trouble breathing. Well, they may be limited by their knees, and they've not been active because they had significant osteoarthritis in the knee. They get their knee replacement, and then all of a sudden, oh, wait a minute, I can't breathe. Or subconsciously, they just don't run up and down the stairs the way they did anymore. And so this is a diagnosis that can insidiously sneak up on people over time. And knowing those numbers, seeing those lung functions early can really sort of help direct therapy and allow for interventions. The other thing is, just because we're here in Kentucky and someone smokes doesn't mean we have COPD. It's definitely something we have to prove. Clearly, there's a ton of different diagnosis in the differential. And if we have someone who's short of breath, but their spirometry is normal, we clearly need to explore other diseases and other options instead of just giving them empiric inhalers and hope that they're going to get better. So I think it's definitely going to help make an earlier diagnosis. Particularly, I would point out, interstitial lung disease. This is a disease where we used to not have interventions for. It clearly can be very rapidly progressive. And if we can sort of find these patients earlier on, we have a potential to have a significant impact in their disease state. So with spirometry, it's a very simple test. It takes just a few minutes to do in the office. Obviously, as our staff gets comfortable doing these tests, we can crank them out very, very quickly. The patient sits down, wears a clip over their nose, and gets a good mouth seal on the mouthpiece that allows capture of all the air in and out. Patient wraps their lips around it, and then they take a big, big deep breath in and they blow out as hard as they can. And our therapists and MAs have gotten really good about coaching these patients with good efforts and good deep breaths in and blow, blow, blow as hard and fast as we can. And what that's going to give us is it's going to give us a piece of paper with spirometry on it. Now, the nice thing about how we're implementing it here at Norton Healthcare is just like the EKGs that we're getting, that they're going to be overread by specialists. So our pulmonary providers will be overreading these spirometries. But at the point of care, when you're getting it, there's going to be a computerized interpretation that's going to help you navigate the results of that test. That being said, spirometry interpretation is pretty simple. And I just wanted to go through a framework here just so that we can make sure we're looking at it and looking at good data. And the first one is it a good quality study? And this actually, the MAs are going to help with a lot of this as part of the test itself. The spirometry software actually prompts the person doing the test, administering the test, to make sure that we're getting reproducible events and we're getting one good blow after one good blow, so that we know that there's enough variation that we can say that this is a valid test. That being said, bad spirometry is still better than no spirometry. And you can have someone who had a horrible, inconsistent test. They couldn't do a good blow from one to the other. But the good thing about spirometry is that it's not going to underestimate. If someone can blow out 1.5 liters and you capture that, that their lung function is at least that good. It may be better, but it's at least a 1.5 liters they're blowing out. So if someone has a bad spirometry, but it's normal, well, that's okay. And that still provides you valuable information. It's also useful for following up, and that you can see, are they having some trends? So some spirometry at least is clearly beneficial, but obviously we like reducible, consistent, so that we can verify and truly confirm our diagnosis. So once we know we've got a good study, then we want to look at our flow volume loops. And it's just patterns. Do we have a nice normal pulmonary function loop as demonstrated in box A here, where we've got a brisk uprise as they're blowing out as hard as they possibly can. And as their volume that they're able to blow out sort of peters off, their flow tapers down, and then a nice big inhale back in. In obstructive disease, where there's this barrier to getting the air out because of dynamic collapse of our airways, we're not going to be able to get that big peak, and we're going to have it tapered out. So hence this sort of flattened obstructive curve. And this is classic pattern compared to a restrictive pattern where someone's lungs are stiff, much like trying to blow up a hot water bottle, where it's just very stiff and non-compliant, that they're going to have these brisk rises and falls in our lung function. And we can see those patterns to recognize, oh, we've got restrictive versus obstructive or normal lung flows. The other thing where a spirometry flow loop can be helpful is looking for dynamic airway compromise. If you have someone who has a tumor, for example, in their airway, either in their neck or in their thorax, we can see these fixed, squared off, either inspiratory, expiratory, or both for fixed flow volume loops. And these, in the right situations, are concerning that there may be some other pathology in the chest or neck that might warrant a CAT scan or other workup. And so that's just something to sort of, as you're looking at your spirometry, to pay attention to. But once we've evaluated that it was reliable spirometry, the flow volume loops were acceptable, then from there, we interpret it. So the first thing is we look at, are your FEV1 and FVC within normal limits? Are they greater than 80%? And if the answer is yes, it's normal, so that we have a normal spirometry. If the ratio is less than 70 of the FEV1 to FVC, then we clearly have an obstructive lung process. And then severity, it's just a matter of looking at how bad the FEV1 is. If it's greater than 80, we've got mild disease. If it's between 50 to 80, moderate. Severe is between 30 and 50, and if it's less than 30%, it's very severe. These correlate with our gold stages that I'm sure you've classically heard about. The other thing to look at sometimes is you may have no obstruction, the ratio may be greater than 70, but your FEV1 and FVC may be reduced from normal. So they might be 60%, 70%, both of them. In that case, that's suggestive, but not diagnostic of a restrictive process. And at that point, you might want to consider a full pulmonary function test. So why do we do spirometry? Well, to make a diagnosis. It can be very helpful, obviously, in the diagnosis of COPD, but particularly with asthmatics or other causes of shortness of breath, just to sort of see, is there an obstructive component, how people are responding to therapy, therapeutic decisions in terms of particularly how you're following up. It's at least once or twice a year, I'll have one of my COPD patients show up in my office who's worse. Hey doc, I'm more short of breath. I can't go up and down stairs, but I check a follow-up spirometry and it's better than it was before. That disproportionate, say, improvement in their lung function as their symptoms are deteriorating, that tells me, wait a minute, do we need to think about some other diagnosis like ischemic heart disease? And that would prompt me to do, say, a stress test looking for ischemic disease and getting our cardiology colleagues involved, or imaging or other workup just to figure out if there's something else going on. So back to our algorithm that we are, grabbing our asymptomatic 45-year-old smokers or history of smoking, and we're doing our spirometry as our rooming were patients, and we'll come back to this. We can ask our MAs to do an MMRC, which I'll discuss in a little bit. But we come to this first box and it's, gosh, I've got someone who's got obstructive lung disease. How are we going to manage it? And this big key here is, do they have asthmatic symptoms that we want to go down the asthmatic pathway to talk about the GINA guidelines, or is this truly just a COPD patient? And then we're going to come down and treat them with gold. So the one thing, and this is a increasing recognized diagnosis, is that all of our patients are not truly necessarily asthmatic or COPD, and that there is a increasingly probably large population in clinical practice that have kind of both. The issue is when all these studies are done to study asthma drugs or COPD drugs, the people designing those studies go to great lengths to make sure that everyone in their population is, say, purely COPD or purely asthma. And so these patients in the middle haven't really been studied well. But if you look at some of the data, there's a large percentage of patients, and it may be 15 to anywhere 55%, who have some COPD and asthma overlap symptoms. I know here personally in the Ohio Valley, where we've got an Armageddon of pollen, a ton of our patients clearly have sort of allergic, allergy, asthmatic type symptoms in the setting of bad COPD. So it's clearly there's a mix of patients that we need to be aware of. And we need to be very careful with this population as well, because there's some data that they may not do as well compared to just COPD patients or just asthmatic patients. So just some basic management. And I think the bottom line here is, if your patient has some asthmatic symptoms, we definitely want to include ICS therapy and make sure they're getting an inhaled corticosteroid, because, as we'll talk about further in a sec, asthma clearly needs ICS treatment if they're symptomatic and needing, daily or weekly therapy to keep that inflammation at bay, to prevent endobronchial remodeling that could lead to fixed airway obstruction. So clearly, if we have an asthmatic we need to treat them asthmatic. And if we have someone who has overlap syndromes, almost certainly ICS needs to be part of that. On the flip side, not all COPD patients need steroids. Steroids in COPD patients have clearly been shown to reduce exacerbations and are clearly indicated. But there is some suggestion in COPD patients that inhaled corticosteroids can increase pneumonia risk. So if you have a stable COPD who's not exacerbating, we don't necessarily want to expose them to that increased pneumonia risk with maybe an unnecessary inhaled corticosteroid. So recognizing as a clinician, where does this patient sit, I think is really important, because there are some nuances in our treatment that we're going to want to consider. So let's say we see our patient and they've got allergic rhinitis, they wheeze with activity, or when they go to visit their family who has a dog, whatever the symptoms are, if you've made the decision, clearly this patient has asthmatic symptoms, then we're going to want to come down the GINA asthma pathway. And we're going to want to make sure that ICS is part of their treatment. Clearly, and just like you would with an asthma, you guys have been doing this for years, based on their symptoms, whether they're mild, moderate, or severe, based on, are they having nightly awakenings? Are they having more than 2 exacerbations, in terms of using their albuterol a week? Those are sort of those cut points where we say, all right, do we need, just ICS, or do you need combination therapy with an ICS and a LABA, or high-dose ICS and a LABA? And then as we're following up, we want to, reassess their symptoms. Hey, are we still using our albuterol more than twice a week? If we are, we probably need to consider escalation of therapy. If we're not, great, observe, follow up down the road, and then evaluate maybe for de-escalation. Coming back here, if we've said clearly, nope, no asthma symptoms, no wheezing, no, wheezing with exercise, I truly think that this is a COPD patient, pure and simple, then we've got to figure out how we're going to break them down into these gold boxes in terms of severity to sort of help guide our therapy. So as our patients are being roomed, as their spirometry is being done, the Modified Medical Research Council Dysme Scale, this has been a validated scale to help gauge symptoms. Really simple and easy for MAs to assess this and enter it into Epic and Notes for us. But it's basically just a simple question. And you ask, how short of breath are they? Based on the questions here, and you can read them. But based on their severity, boom, done. So if they have to stop after walking 100 meters or after a few minutes, that would be a grade 3. Real quick and easy, simple to do. But it's important because based on their symptoms, in terms of if they're not very symptomatic versus they're very symptomatic, that's going to help gauge us into our, ABCD gold, criteria. And then the question is how often are they getting hospitalized, or how often are they having exacerbations? And so we have people who are not being, don't have frequent exacerbations versus C and D who do have frequent exacerbations. So our D patients are patients who are having exacerbations, getting hospitalized, and are symptomatic. These are the patients who are being seen in the ICC, calling for frequent antibiotics. And these are the patients that we want to do everything we can to reduce those exacerbations and hospitalizations. Whereas our A patients, they clearly do better with some pharmacologic support, but don't require the level of intensity of our sicker patients. So once we figured out where they are they asymptomatic non-exacerbators or are symptomatic exacerbators, that's going to tell us where we need to fall down here. For our non-hospital exacerbating patients, these are the patients that don't need the inhaled steroids. These are the ones that can do fine with just a long-acting beta agonist or muscarinic agonist or combination therapy without the ICS. Whereas our patients who are getting in the hospital, they're the ones who are symptomatic in the hospital. They are going to benefit from triple therapy. They're going to benefit from that ICS to reduce that exacerbation risk. The other thing I throw in there is obviously pulmonary rehab. This is very beneficial, for everyone from B on over. just in terms of reducing long-term symptoms and mortality. And finally, the big thing here at the end of all this, once we've made a diagnosis of COPD, we figured out what therapy we want to have them on, is consideration of Alpha-1 antitrypsin screening. And I throw this out there, and it's the World Health Organization clearly recommends that this is something that needs to be pursued and diagnosed. It is a genetic disorder that runs through families, and it does increase the chances of someone having rapidly progressive obstructive lung disease that's frankly preventable. It's the double whammy of not having the Alpha-1 antitrypsin to protect you from the oxidative, assault of inhalational injury, leading to accelerated lung damage. And in those patients, frankly, a lot of time, they just don't smoke and avoid those inhalational assaults, they'll do fine and they won't have a problem, particularly if we can identify them early. But if they catch later, obviously in patients where it's appropriate, we can give enzyme replacement and slow down progression of disease. So it's clearly something that we want to test and identify for. The good news is it's easy. And this is a test kit. We've actually have these kits that can be made available to everyone in primary care. It's a simple finger prick test, and they mail off. There's no cost to the patient whatsoever. It does take a couple of weeks to get back, but when we get it back, we get their both their numerical value of what their activity is in terms of their Alpha-1 activity, enzyme activity, but we also get their phenotype, whether they're that is, they're totally fine, or if they're MS, they're a carrier for the disease, in which case we can then do free testing on other family members and try and catch those people early before they progress. Or frankly, are they SS or SZ and truly have disease and warrant discussion and consideration for enzyme replacement. Again, these tests are free to the patient. They're really simple to do. We've set up an order within Epic for POC, point of care Alpha-1 antitrypsin testing that allows it to be flagged within Epic so that you can use the result reporting tab to report these results back to the patient, when they do come back. All right, so we've gone through all this, finally at the end of all this is see the patient follow-up. If you think it's appropriate, consider follow-up spirometry. I think my hope is, selfishly, is that as everyone gets more comfortable with spirometry, as we're screening our asymptomatic 45-year-old smokers or former smokers, that spirometry will become more common and familiar within the practice, so that when someone comes in short of breath, that we can just do spirometry's routine to help guide, clinical decision-making. Obviously, if people are not responding appropriately, consider a full PFT to evaluate for other coexisting diseases. Obviously, you can have COPD with underlying fibrosis, pulmonary hypertension, other conditions simultaneously. So it's always worth revisiting, doing further workup, and in a shameless plug, but obviously under the recommendations from our primary care providers who helped develop this, consider pulmonary referral when appropriate, particularly for these sicker patients. And I mentioned specifically with asthma and these, overlap patients, we've got some new drugs that we didn't have, 10 years ago in terms of biologic medications that specifically target the cells that are causing this uncontrolled inflammation and really have seen some phenomenal response to therapy. So if you have an asthmatic or a patient who's requiring multiple steroid pulses, multiple exacerbations per year, please consider them for referral, because I think considering those patients for biologic therapy can make a big difference in their long-term care and symptom control. So I wanted to just close out with some other things that are sort of all tied in with COPD and the management, and we'll just touch on these last few things as we end the talk here. Obviously, tobacco cessation. It is so important. And again, I hark back to the Fletcher curve. The biggest intervention is tobacco cessation. Inhalers can help people. They can reduce hospitalizations. They can reduce symptoms. but they don't stop progression of the disease the way that tobacco cessation does. Obviously, there are lots of different options out there. And we've had a subgroup committee working to create tools and education that we will distribute out to all the primary care offices on helping, both with managing this, but also documentation, both for billing purposes and for patient education. Nicotine replacement therapy clearly helps. A combination of a patch for sort of long-term control and short acting for those crazings has been shown to be beneficial. I referenced one study here with varicocicline, where they were used with smokers who had acute coronary syndrome, and they started therapy in the hospital and continued as an outpatient, and clearly had an improvement in abstinence and was beneficial. The only other little clinical pearl I throw out there is with bupropion. It's one of those you want to think about. If you've got someone who has a seizure disorder, that's not a drug you want to use. So the cornucopia of inhalers, and I'm sure you've seen these charts before. These are incredibly helpful. Often people will show up and have no idea what inhaler they're on, and being able to point at the color of the one they're on is very helpful. It helps identify, are they on the long-acting muscarinic antagonist, the long-acting beta agonist? Which inhaled corticosteroids are they using? Which short-acting are they using? And then the various combinations of all the different classes together. And unfortunately, this is a big challenge. One of the biggest problems with managing, COPD, and for that matter, asthma, is inhalers. And it is inhaler cost, inhaler use. These inhalers, some of them have to be used different ways. Some of them are once a day, twice a day. Some of them need a spacer, some don't. And clearly, there's lots of data that patients don't use these correctly. And that's despite repeated educational efforts. I think it's very important with every visit going through and making sure the patients are taking the inhalers the right way. A lot of them, particularly have inhaled corticosteroids in them, and those, because of the risk of thrush, you got to rinse your mouth out afterwards. And so what I do with my patients is I recommend, hey, leave your inhaler next to your toothbrush. So when you get up in the morning, you can take your inhaler and then rinse your mouth out, because I found that helps with compliance as well as reduces the side effect of thrush with the ICS.